But I would like to introduce Dr. Shirling Tsai, Assistant Professor of Vascular Surgery, UT Southwestern. Spends a lot of time at the VA doing vascular surgery for us, and we are lucky to have her. She helps with the access, helps with TAVR. She's here to talk about EVAR for everybody today.
No. Okay. Okay, good morning. Thank you for, I first want to start by thanking Drs. Banerjee and Berlakis for inviting me here to this conference and giving me the opportunity to talk about catheter-based aortic interventions, more specifically innovations in endovascular aortic aneurysm repair. Microphone. I have no disclosures. So this is a brief outline of the topics I'm going to cover in the next 10 to 12 minutes. So aneurysms, abdominal aortic aneurysms, are defined as a dilatation in the abdominal aorta that exceeds the normal aortic diameter by more than 50%. So by absolute measurements, any segment of the abdominal aorta that exceeds 3 centimeters in diameter would be considered aneurysmal. Nearly all AAAs involve the infrarenal aorta, and most of them are actually limited to the infrarenal aorta. So in terms of epidemiology, AAAs are most common in older men. In men aged 65 to 80 years old, the prevalence is about 4 to 7%. And this was shown in several large European screening, aneurysm screening and natural history studies. And it was also shown in the US ATOM trial, which is a US small aneurysm trial. And from both of these studies, we can also see that the prevalence of aneurysms, or abdominal aortic aneurysms specifically, in women is much less than in men. And this is consistent with the notion that men are probably 6 times more likely to have a AAA than women. So the risk, aneurysm rupture is associated with up to 80% mortality, and the risk of rupture is directly related to aneurysm size. So at what size should we fix these aneurysms? Well, this was determined by 2 large randomized controlled trials. The ATOM trial, which was done in the United States, actually based in the VA population, and the UK small aneurysm trial. These 2 trials are large randomized controlled trials. They randomize patients with aneurysms between 4 and 5.4 centimeters to either continued surveillance or immediate open repair. And the 2 trials came up with the same conclusion, basically that there is no benefit to early aneurysm repair. And based on the data from these trials, we follow the recommendation that AAA should be repaired electively when they grow to be bigger than 5.5 centimeters. So open aneurysm repair has been around for decades. One of the first reports of open aneurysm repair was in 1954. This was a description of 17 patients who underwent replacement of the aneurysmal aorta using Vinion and cloth, which was basically leftover parachute material that was donated from the Union Carbide Company. So we've come a long way from the hand-sewn, handmade graft in the 1950s to Dr. Perotti's first report of endovascular repair in 1991. And this really introduced the concept of excluding the aneurysm rather than replacing the aneurysm. So here is a schematic of the 2 techniques, open repair versus endovascular repair. And in the open repair group here, this is a standard open repair, you can see that the aneurysm, which is this dotted line here, is basically replaced by this tube graft, which is sewn in proximally and distally. This is a schematic of a typical endovascular repair where the infrarenal aorta is essentially relined with this covered stent that's delivered through bilateral common femoral artery accesses. So instead of replacing the aneurysm here, the aneurysm is really excluded from the circulation. So over the last 20 years that we've been performing EVAR, we've gained a lot of experience with it, and we've actually accumulated a fair amount of data that confirms not just the safety, but also the efficacy of endovascular repair for infrarenal AAA. There have been 3 large trials that compare open to endovascular repair. One is the OVER trial, which was done in the US VA hospitals. One is the DREAM trial, which was done in the Netherlands. And one was the EVAR-1 trial done in the United Kingdom. And all of these trials basically came up with the same conclusions. First, that the 30-day mortality was largely in favor of EVAR, so very much decreased perioperative mortality. But at 2 years, this survival advantage had disappeared. These are the midterm data from the DREAM trial, and you can see that at 2 years, there is no statistically significant difference in survival between the two groups. So really, the whole survival advantage can be attributed to the decrease in perioperative mortality. But what about durability? How durable is EVAR compared to open repair? And so a couple years ago, both the EVAR trial and the DREAM trial published their long-term results in the New England Journal, and this is the long-term outcomes from the DREAM trial. And you can see that at 7 years after randomization, there's no difference in actuarial survival between the two groups. So this is our best data telling us that EVAR is as durable as open repair. There was a slightly increased rate of secondary interventions in the endovascular group, but even this point could be disputed because in the US open versus endovascular repair trial, which was the OVER trial, there was actually no difference in the rate of secondary therapeutic interventions. So given all the data in favor of EVAR, it's no surprise that over the last 2 decades, there's been a real dramatic change in how we manage infrarenal AAAs. This is single institutional data from the Massachusetts General Hospital, and you can see that in 2005, already 70% of infrarenal AAAs were being repaired endovascularly, and today we estimate that over 90% of infrarenal AAAs are repaired endovascularly. So we have a wide array of devices available to us for endovascular aneurysm repair, and these are just a couple of them. They are all a little bit different. Some of them have suprarenal fixation, some don't. They have different stent material, nitinol versus stainless steel. The fabric is different. Some have Dacron, some have PTFE. The stent shape is different. The stents are different, spaced differently. Everything is a little bit different from each one, which means every device has a different IFU. But luckily, they all have some features that are important that are all in common. Every device needs some sort of some area of infrarenal aorta that is healthy and non-aneurysmal that would provide a proximal seal. This prevents blood from leaking around the graft into the aneurysm sac and pressurizing the sac. Generally, this is 10 to 15 millimeters long. It can't be too big and it can't be too angulated, meaning the aorta can't be too tortuous there because that would compromise the seal area. Likewise, you need some area of distal seal in non-aneurysmal healthy common iliac artery. And then these devices today often can be delivered through 16 to 20 French sheaths. And so the iliac and the common femoral arteries have to be big enough to accommodate these large bore sheaths. So what happens when we treat patients who don't quite meet all of these anatomic requirements? Well, these studies have shown that the outcomes are not as good, but this one study really highlights the issue. These authors looked at over 10,000 patients in the M2S database. M2S is a big imaging database. And they found that almost a third of patients had anatomy that would not fit in the most liberal IFU requirements. And this is important because at 5 years, they also found that over 40% of patients developed AAA sac enlargement, which means that their aneurysm size grew by more than 5 millimeters after the EVAR was done. And in fact, the incidence of sac enlargement was significantly higher in patients who were treated outside of their device-specific IFUs. So clearly there are downsides to treating patients who don't quite meet all the anatomic requirements for these devices, which is why a lot of the new devices coming out on the market have been designed to overcome some of these anatomic limitations. And here are just a couple examples. The trivascular ovation graft, their proximal seal is, instead of having a proximal seal zone, the proximal seal is based on these sealing rings that are filled with polymer, and the polymer actually solidifies at the time of device implantation. So this is designed to address irregularly shaped necks that are reverse tapered, conical, have some thrombus in them, have calcification. The AR fixed graft is based on these interlinked nitinol rings that actually provide a high degree of flexibility to the graft. So this graft is designed to deal with very tortuous aortas, so necks that are angulated up to 90 degrees, in fact. And lastly, the endo anchors are these helical screws, really, that are meant to tack the graft to the aortic wall. So this is meant to either reinforce the proximal fixation or seal zone and is supposed to simulate a surgical staple line. And lastly, there are many devices that are still in clinical trials. So iliac branch devices, for example, to preserve the hypogastric artery in cases where the graft has to be extended past the common iliac artery into the external iliac artery. The Naglex device from Endologics, this is a whole new approach to aneurysm repair. This device fills the whole sac with polymer and then leaves 2 flow channels to perfuse the legs. And then, just like everything else in cardiovascular interventions, everyone is striving to achieve a lower profile. And Cordis has a graft that is in clinical trials, and when that is on the market, it will be the lowest profile device at 13 French, hopefully. So, in contemporary practice, the majority of infrarenal AAAs are managed by EVAR. But what about patients who have more complex aneurysms, juxtarenal aneurysms or suprarenal aneurysms, aneurysms that really don't meet any anatomic criteria for any of the available devices? So in these patients who are good operative candidates, open repair is actually a very good option. But in patients who are not good candidates, we're actually very lucky to have here at UT Southwestern and the Dallas VA a very robust fenestrated EVAR program. In the United States, there is only one fenestrated device that's available on the market, and that is the Zenith fenestrated graft. This graft comes with 3 custom-made fenestrations that can provide perfusion to the renals, SMA, and celiac, or a combination of the 3 of them. And basically what this graft provides is that we can now move the graft from the immediate infrarenal position all the way up into the paravisceral position while maintaining perfusion to the renals, SMA, and the celiac. So here's one case that we did. It's a 91-year-old man who had a 6-centimeter juxtarenal AAA. And on this CAT scan, you can see that the immediate infrarenal aorta is already a bit ectatic. These are not parallel walls. It's already starting to balloon out. So that would not be a good proximal seal zone. But if you look here at the suprarenal aorta, this is nice and healthy aorta. So this patient was treated with a Z-Fen device, and this is his completion angiogram. On the x-ray, you can see here are the outlines of the renal artery stents, and this device goes well up above the renal arteries. And on the angiogram, you can see that both renals are patent, and on the lateral view, you see the perfusion to the SMA. And here is his 30-day CTA, which shows perfused renals and the SMA and good stent position, and overall a very nice result. So that's all I have. Thank you.